Good afternoon. I'm Lorna Lucas, Assistant Director of Provider Education for the Association of Community Cancer Centers. I'm eager to introduce Dr. Sigrun Hallmeyer, our expert presenter for the 12th eCourse of the first year series hosted by the Institute for Clinical Immuno-Oncology, or ICLIO, who will discuss new mechanisms in cancer immunotherapy. As you may know, the ICLIO initiative focuses on preparing the multidisciplinary team for the challenges and opportunities presented by immunotherapy, includes other vital resources such as newsletters, papers, a scholars program, and our national conference, which will be held September 30th in Philadelphia. Please visit www.acc-iclio.org to browse all of our offerings. Now for today's course, I'm pleased to introduce Dr. Sigrun Hallmeyer, Director of the Oncology Specialists Research Institute and Medical Oncologist at Oncology Specialists SC in Park Ridge, Illinois. Additionally, Dr. Hallmeyer serves as the chair to the Cancer Committee and as director of the Survivorship Program at Advocate Lutheran Hospital. Dr. Hallmeyer is also an esteemed member of our ICLIO Advisory Committee. Dr. Hallmeyer joined Oncology Specialists in 2005 and provides novel and cutting-edge therapies not available elsewhere in the framework of clinical trials, which present important and vital advances to the field of oncology and to the patients. Dr. Hallmeyer attended medical school in Germany and completed her fellowship at the University of Illinois at Chicago. Dr. Hallmeyer has done research in breast and prostate cancer as well as melanoma, and her current research is focused on breast cancer and melanoma and functions as a principal investigator in several clinical trials. She has published work and has presented her results at international meetings. Now for a few housekeeping notes, please feel free to submit any questions you have to our presenter by typing your questions in the box on your dashboard. We will also be joined by Dr. Jake Ginto with McGivney Global Advisors, who will pose questions to Dr. Hallmeyer at the end of our presentation. This webinar will be archived and will be available on the ICLIO website shortly. Now I'll send it over to Dr. Hallmeyer to kick off the webinar.
All right, good day everybody. I'm very happy that you're all able to join us on such a wonderful, for us it's a winter day. I'm in Chicago, so we have a little bit of snow on the ground. And so I'm very excited to be invited to give this webinar here today on a topic that's very dear and near to my heart. I joined my group about 11 years ago, fresh out of fellowship, and sort of dove into the world of immuno-oncology. And really in that now almost decade of a clinical experience have really learned to love the world of immuno-oncology as holding the promise of truly being the holy grail of potentially curing patients with solid malignancies and liquid malignancies. As you probably all are aware, there have been multiple FDA approvals just in the last now 5 years, starting with ipilimumab, Yervoy. And what we designed this particular course to be today is essentially looking a little bit outside of the beaten path of the immune checkpoint inhibitors and cytokines. And so with that, maybe let's move forward right here to the next slide to give a little bit of an overview. And so the objectives for our 45-minute being together here today is that we would like to review and ultimately understand the mechanisms of action of immunotherapies other than the cytokines and checkpoint inhibitors in the development for the treatment of cancer. And I hope that I can leave you with a good understanding of the clinical evidence supporting the use of these different immunotherapies in treating patients with cancer today. Move to the next slide. And so the immunotherapy background really stems from our many, many years and decades of use of cytokines that have sort of paved the path of understanding how immune cells have capacity to interact with human malignant cells. Cytokines in general are naturally occurring molecules, and they act directly on the immune system by eliciting an immune response, ideally against tumor cells. These cytokines are the principal effector agents of inflammation and sepsis. So if you have a patient who is admitted to the intensive care unit with a severe sepsis, they will have very, very high levels of endogenous cytokines. And so what we have learned in the world of cancer immunotherapy is if we sort of exogenously provide these type of cytokines to patients who have cancer, we can induce, in some cases, very, very striking responses against their own malignancy. And you see two different examples that are listed on the slide here, the interferons, which are still currently in the marketplace in the United States and elsewhere for the use of adjuvant therapy in malignant melanoma, and specifically the pegylated form, the PEG interferon alpha-2b, is a very good example of using cytokines in clinical practice, reducing the risk of disease recurrence. It's not our greatest agent to do that, and we'll get to that later, but really from a background perspective, it has taught us a lot of things in the understanding of the interactions between T cells and melanoma cells, and probably provided much of the background that has led to the very brisk research that's going on with the other agents that we'll be talking about. The interleukins, also falling into the class of cytokines, is a very interesting drug class and is very, very highly toxic. Again, if you understand that these are the principal effector agents causing inflammation and sepsis, you will understand that patients that receive this type of therapy in multi-million doses, that patients will have very significant side effects. But as exemplified here on the slide for renal cell carcinoma, a very significant minority of patients can actually achieve complete and durable remissions with application of the cytokine therapy. And so again, that has sort of led the way to understanding that maybe if we interact with a patient's immune system, we can ultimately lead to durable remissions of their malignancy. Now let's move forward to the next slide, and that slide is giving a very broad overview of what is currently the big buzz in the world of immuno-oncology, and that is the checkpoint inhibitors. The first that came onto the market and was presented in a plenary session at ASCO in 2011 was the molecule that is presented here in cartoon form. On the left is CTLA-4 inhibitor, one of which is Yervoy or ipilimumab. And just really briefly, the way it works, it's an inhibitor of the negative feedback regulation that antigen-presenting cells or dendritic cells exert on active T cells. So in the presence of that particular interaction between the APC and the T cell, an activated T cell is no longer able to exert its cytotoxic activity against, say, a malignant melanoma cell. And so this particular immune checkpoint inhibitor has been very, very successful in a minority of melanoma patients in inducing very significant and deep and often very long-lasting responses. And that was really sort of the first generation in clinical application of checkpoint inhibitors. And of course, most of you are very familiar with the newer generation now, which is the PD-1 inhibitor class, exemplified on the right side of the cartoon here, where you see the interaction that normally takes place between tumor cells and T cells, where unfortunately tumor cells may have gained the ability to negatively interact with T cells in such a fashion that a very highly educated and specifically stimulated T cell may arrive in a tumor tissue environment, but ultimately will be turned down by the tumor tissue cells, but via the direct interaction of the PD-L1 on the tumor cell and the PD-1 receptor on the T cell. And so what these monoclonal antibodies, these PD-1 inhibitors that we now have on the market do, they essentially competitively inhibit on these receptor ligand areas and ultimately make it impossible for the tumor tissue ligands to connect with the receptor surface on the T cell. And as a net result, you will have persistent activation of T cells. So the highly educated and stimulated T cell that has arrived in the tumor tissue environment can in fact actively exhibit its cytotoxic activity. And so these are two very good examples of how we as humans can interact directly with the tumor tissue environment and T cell interaction by inhibiting the inhibitor. And again, our talk today is on the background of having done a lot of research with the checkpoint inhibitors and cytokines, but really what else are we looking at to really produce more specific and durable and potentially less toxic immune responses in the world of malignancy. And so let's move forward to the next slide. And so the immunotherapies are being used in multiple different scenarios. They are really no longer a niche therapy. Multiple oncologists and no longer the big academic centers and the NIH are investigating in big research clinical trials, and there's multiple applications in a large number of different tumor types. You see multiple different immunotherapies that have just in the recent past achieved FDA approval. Of course, prostate cancer with Provenge or Cytokines-T, melanoma, you're very well aware of the ipilimumab and the two PD-1 inhibitors on the market. pembro and nivolumab, as well as the interferons, and really also interleukins still. And in non-small cell lung cancer, across the board of squamous and non-squamous etiologies, we have nivolumab and pembrolizumab. And very recently, just now, FDA approved also nivolumab and historically interleukins for renal cell carcinoma. So the world is really expanding. It's no longer the very rare malignancies, and there is over 1,000 clinical trials currently ongoing investigating different immunotherapeutic approaches in all kinds of cancer scenarios. Let's move forward to the next slide. And so in that, we would like to concentrate today not so much on the cytokines and monoclonal antibodies and checkpoint inhibitors, but really talk a little bit more about the vaccines, cell therapies, and oncolytic viruses. And those are all in late-phase clinical trials that I would like to introduce to you and sort of talk a little bit about mechanism of action and early clinical data. Let's move to the next slide. So vaccines is a very, very broad category of multiple different approaches that can be considered under this umbrella of therapy. And it can involve target cells that are T cells and target cells that are B cells, ultimately with the goal to induce an immune-specific response against a tumor cell. B cells principally are cells that are producing monoclonal antibodies that ideally have specificity and high affinity against tumor-specific antigens. And so these cells need to be trained to produce these cells in high enough numbers. And the big culprit in that particular endeavor is that tumor cells need to be what we call immunogenic. You need to have a tumor-specific antigen that can be targeted with such an antibody. T cells are much more complicated. They need to be stimulated by antigen-presenting cells, and they need to have certain surface molecules on their surface that are able to recognize tumor tissue-specific antigens to which they connect and ultimately exert their cytotoxic activity. And any of those actions between T cells and tumor cells and B cells and tumor cells can be enhanced with vaccination therapy. The idea really is that vaccines introduce the immune system to tumor-associated antigens and inducing the immune system to recognize these cells and attack them and essentially exert a very specific, highly cytotoxic activity that should be relatively non-toxic because, again, the specificity that comes with this system is tailored to recognize only surface proteins that are unique to the tumor. Let's move to the next. Now, enough about the theory. What does that really look like at the bedside? So one of the very stimulating clinical trials is this Prosca clinical trial. It's a vaccine. It's a mixture of PSA, which is the prostate-specific antigen, together with IL-2 and GM-CSF, the granulocyte macrophage colony-stimulating factor, or also marketed on the U.S. market as Leukine. Now, we all, of course, know that PSA is a very specific molecule that's produced by the prostate gland only, which makes prostate cancer such a unique and very interesting model for immunotherapeutic research because there is no other tissue in the body that produces that. And so if we can produce a vaccination that's specific against that, you can actually have a very tailored response by the immune system against PSA-producing cells. IL-2, as we know, as a cytokine, increases the amount of white blood cells and ultimately enhances the immune response. And then lastly, GM-CSF assists in the formation of white blood cells in the bone marrow and supports antigen-presenting cells. So this is sort of a very potent mix to produce a very active and very specific immune response against a very unique antigen, the PSA. Let's move to the next slide. And so the trial that is currently ongoing is a phase 1A, phase 1B trial for the treatment of patients with recurrent prostate cancer. You see the eligibility listed here, patients with recurrent prostate cancer, proven by an elevation of their PSA serum levels. They have to have had prior definitive therapy, including surgery or radiation, and that is typically to prevent severe prostatitis, because essentially what we're trying to do is to vaccinate this patient against PSA-producing cells. And if they still have a prostate gland in place, you will induce a very severe and often very painful inflammatory response in the organ. So patients, to be eligible for this trial, need to have had definitive surgery to remove the prostate gland, either surgically or by radiation. and they will receive this particular vaccination intradermally. The endpoint for this particular clinical trial is dose-limiting adverse events because it's a phase 1 clinical trial, so we're looking at safety. But secondary endpoints are clinical endpoints, including PSA doubling time and the prostatic acid phosphatase levels, time to measurable disease, time to subsequent therapy, as well as overall survival. And they're also looking at some immunologic endpoints, including vaccine-induced immune responses, for instance, the anti-PSA antibodies, as well as lymphocyte activation assays and cytokine levels release assays. Go to the next slide. And so the initial results of this particular clinical trial were actually very, very promising. They had patients receiving this intradermal injection of the vaccine in week 1, 2, 3, 7, 11, and 15. And 12 patients received at least one of those vaccinations, and the vast majority of those, 10 of 12, were able to receive all 6 vaccinations. And that sort of gives credit to the ultimate understanding if we design these vaccines well, they are typically extremely well tolerated. This is a very, very tolerable form of immunotherapy. They really did not encounter any dose-limiting adverse events for any patients receiving vaccinations. And 7 of the patients tested had increased immune responses to PSA. So that sort of is a proof of principle that you are indeed able to develop a T-cell specific response against the PSA producing cells. Now, from a clinical perspective, the investigators also observed clinical activity with 2/3 of the patients being treated taking the vaccine experiencing decreasing PSA levels, which is clinically very meaningful. And again, very well tolerated, no dose-limiting adverse events. And so based on this very early phase 1 clinical trial with a very limited amount of patients participating, there is now a phase 2 trial planned enrolling over 120 patients in the very near future. Let's move forward. Now, the basis of many approaches in immuno-oncology is to utilize a viral or bacterial vehicle to incorporate foreign cell functions into cancer cell functions that it typically would not express. And one of those examples is the CRS-207, which is an immunotherapy vaccine that is currently in development for really a number of tumor types. Now you see exemplified here the actual platform. So it's a live-attenuated, double-deleted Listeria bacterium. You see on the left side a cartoon that is essentially telling you that the genetic information that is contained within this bacterium has been engineered and attenuated and genetically modified in such a way that 2 genes, the internalin B and ACT-A, have been deleted from this vaccine genetic information. And these particular 2 genes were essential for the bacteria's natural ability to harmfully infect hepatocytes and spread. And so this particular platform can now be genetically manipulated to express tumor-specific antigens. And in this particular platform model, the SRS-207, it has been modulated to express the tumor-associated antigen mesothelin, which is a protein which is expressed in a number of different tumor types. And we're going to go through some examples in the next 2 slides. Let's move forward. And so here is an example of a very, very promising pancreatic clinical trial. As you all know, it's a very, very difficult disease to treat, and unfortunately many of the targeted agents as well as non-specific chemotherapeutic agents have been very unsuccessful in really changing the outcome for advanced disease. And so this really laid a big foundation for the motivation to invest in immunotherapeutic approaches for this disease. The initial and very promising phase 1 and phase 2 clinical trials were circling around the GVAX that you see on the bullet point underneath here, which is a pancreas vaccine consisting of allogeneic pancreatic tumor cells. They're derived from cell lines. And these are genetically engineered to express GM-CSF. And in the clinical trial that is exemplified here on the slide, they're using this already well-approved GVAX Pancreas vaccine strategy in combination with this Listeria vaccine platform that we just talked about, the CRS-207. And what you see in the table summarizing here is the phase 2A randomized study that randomized patients to 2 doses of the GVAX, the cell line-derived vaccine, plus the CRS-207, in addition to cytotoxic chemotherapy with cyclophosphamide, and compared, if you will, that triple therapy to doublet therapy of GVAX versus cyclophosphamide alone. And you can see that this led to almost a doubling of the overall survival in the study group. And there was also a dose relationship in terms of duration of response. The longer patients were able to receive this immunotherapeutic-based vaccine, the longer the duration of response and survival was, as you can see in bullet point 1 underneath the table, 9.7 months for the triplet compared to 4.6 months for those only receiving GVAX and cyclophosphamide. And again here, as it is true for most vaccine strategies, extremely well-tolerated therapy. And so in that, again, we're planning on additional clinical trials, now also incorporating the newer and now FDA-approved checkpoint inhibitors that are really believed to bring this much further, looking now at a phase 2B clinical trial, looking at this CRS-207 GVAX platform, in addition with nivolumab, a PD-1 inhibitor, in the ongoing STELLAR clinical trial. Now let's move to the next slide. Now, as I said, this SRS-207 platform with the mesothelin is really not tumor specific. There's multiple epithelial type of cancers that express this, where this platform can be utilized as an immunotherapeutic sort of backbone, if you will. And mesothelioma, very much like pancreatic cancer, being another disease where we have high motivation to find something, you know, if you will, outside the box, because our typical cytotoxic therapy has been very disappointing in that clinical scenario. And so here is another clinical trial utilizing that same diphtheria platform, SRS-207. And what is represented here on this slide is an interim analysis of a phase 1B clinical trial of utilizing that platform in combination with the standard first-line chemotherapeutic combination of pemetrexed and cisplatin. And this is used as front line. So, you know, for us immunotherapeutic researchers, the question always is, well, when should we really investigate an immunotherapy for these patients? And the idea really is that you would like to have an as much immunocompetent host as possible. And so the first-line setting is typically sort of the holy grail of our patient population that we would like to accrue to these clinical trials, as has been done here. And so you see that patients receive 2 vaccinations with this platform, SRS-207, 2 weeks apart, and then they received up to 6 cycles of the standard chemotherapy with pemetrexed and cisplatin, and then again 2 additional doses of the CRS-207. And they had 34 evaluable patients with a very, very striking disease control rate of 94%, which again, this is a difficult controlled disease with standard therapy. 59% achieved partial responses, 35% were judged to have stable disease. They were actually very scientific in this clinical trial and also tried to achieve tumor biopsies after completion of therapy. And in 3 patients where this was successful, they conducted biomarker analyses that revealed a very interesting finding, an increase in tumor infiltrating cells, which is a hallmark of immune response. If you're able to recruit CD8 positive T cells into the tumor tissue environment. And the median duration of response is really very significant at 5.3 months with a progression-free survival of 8.5 months. And again, I want to remind you that this is a phase 1B trial, very, very early data. So we're expecting final results for this early trial later this year, but a phase 3 trial of this platform, the CRS-207, in combination with chemotherapy in the first-line setting is being planned and should really go forward based on this very, very promising result of this early clinical trial here. Let's move forward. Now, this immunotherapy in the world of cell therapies is a completely different concept. The idea really is, as is sort of illustrated here in the cartoon, that patients' T cells are collected from their peripheral blood, typically by a leukapheresis type of approach. And the T cells that are isolated are engineered to express what we call a chimeric antigen receptor, or a CAR, C-A-R, that recognizes a ideally specific tumor antigen. And these engineered cells are ex vivo then expanded and grown and ultimately reinfused into the patient. And the idea is that these engineered T cells recognize attack and ultimately kill the antigen-specific tumor cells. So this is an adoptive cell transfer type of cell therapy, and this may sound very utopic, but it's already in clinical practice with things like the Provenge against prostate cancer. Now let's move to the next slide, please. And so I really have practiced this word a lot, and I'm not quite sure if I'm going to be able to put this onto this teleconference here. Tisagenlecleucel-T, or CTL-019, is in phase 2 currently for the treatment of children and young adults with relapsed and refractory acute lymphoblastic leukemia. This is a universally fatal disease. These patients that have relapsed and have refractory disease typically have a very short median overall survival. And so anything that can make a difference here would be considered a significant advantage. And so this particular platform of cell therapy, the CTL-019, the patient's T cells are collected very much like we discussed in the previous cartoon and genetically modified to express this chimeric antibody that recognizes CD19, which is expressed on the cell surface of these particular tumor cells. And so there was a phase 2 single-arm study in these refractory and relapsed acute lymphoblastic leukemic patients, in almost 60 patients, and 55 out of those 59 enrolled patients, which represents 93% of patients, achieved a complete remission. This is jaw-dropping. This is a very refractory patient population. This is a pure immunotherapy that is inducing a T-cell specific population against CD19. The overall survival at 12 months for this patient population was 79%, and 18 patients had ongoing complete remissions after 12 months, a year after therapy. Now, this is not a well-tolerated therapy, as we discussed with the other vaccine therapies. 88% of those patients treated developed cytokine release syndrome that consists of hemodynamic and respiratory instability. But the good news here is that this syndrome is reversible, and in this particular clinical trial, it was reversed in all cases with an IL-6 receptor antagonist. And so based on this really jaw-dropping result of this early clinical trial here, the FDA granted this particular platform a breakthrough designation, which really means that they open the floodgates in terms of sponsoring further clinical trials specifically for the pediatric and adult ALL population. And it is currently in phase 2 for other hematologic malignancies as well. So this is certainly something to stay tuned on. Very, very interesting cell therapy platform. Let's move forward. Another one that's a little closer to what I do in the world of metastatic melanoma is the LN-144, which is a phase 2 clinical trial for patients with metastatic and refractory malignant melanoma. Here, how we derive these T cells is actually a different approach. You know, the one that we just discussed previously is typically a leukapheresis type of approach, and then ex vivo cell expansion. Here we are actually looking for tumor infiltrating lymphocytes, or TIL cells. These are highly trained, very specific T cells that are ideally already stimulated by a corresponding dendritic cell to recognize tumor-specific antigens. And they are enriched within the patient's tumor specimens and can be directly derived from tumor tissue biopsies. So the way this is done is that the patient's tumor is harvested, and then these tumor-infiltrating lymphocytes are derived from that tumor specimen, expanded into several billion, and then they will be reinfused into the patient after they have been expanded in vitro. Patients undergo a lymphodepletion before they receive their cells back, and then are stimulated with interleukin-2 as well. And you can see in the table form underneath, the overall response rate at 54% rivals what we see with the modern cytokine, with the modern checkpoint inhibitors. It's a very, very significant number. Our historical immunotherapeutic response rates with cytokines were in the single digits. So being with this particular TIL therapy, over 50% response rates is really very, very impressive. Moreover, almost 1 out of 4 patients achieved a complete remission. And if you were the lucky 1 out of 4 of those patients, the vast majority, 96%, showed durability of response up to 47 months following treatment. So again, showing that this immunotherapeutic approach really holds the promise of inducing very deep and durable responses that could be potentially life-altering and maybe even life-changing, life-saving. The overall survival was 80% at 12 months, and if I may remind the audience, as little as 5 years ago in 2011, when ipilimumab was approved onto the market, our benchmark for overall survival at 12 months was 25%. So historically, as little as 5 years ago, with a metastatic malignant melanoma in a stage 4 scenario, your chance of being alive at 12 months was only 25%. And with these new immunotherapeutic interventions, we're now scratching the 80% mark, which is really, really remarkable. The median progression-free survival in this particular clinical trial was 10 months, and a third of patients experiencing no disease progression at 4 years following their therapy. So really, this is a completely new era of treating solid malignancy, and melanoma is certainly lighting the way with much of this research being done in that particular disease, but we've expanded that umbrella so much beyond just melanoma. Let's move to the next slide. Now, T-Vec is actually one of the few therapeutic interventions that we're discussing today that has already achieved FDA approval just a few weeks ago. It is approved, as you see in the bottom box, for patients that qualify for local treatment of unresectable cutaneous, subcutaneous, or nodal lesions recurrent after initial surgery. The mechanism of action is actually very, very interesting. It's a modified herpes virus, type 1. It's an oncolytic virus, so it specifically infects melanoma cells and leads to cell lysis. It replicates within the tumor cells and produces the immune stimulatory protein GM-CSF. So it's similar to the GVAX that we discussed earlier for pancreatic cancer, where we go back to the immune stimulatory agents, and if we can sort of force tumor cells to express proteins that it normally wouldn't, but ultimately essentially force these cells to stimulate the immune system while being infected with a virus that causes lysis of these cells, we can have sort of a win-win situation. When it works, the T-Vec causes the tumor cell to lyse, releasing tumor-derived antigens, which along with this GM-CSF promote anti-tumor immune responses. Let's move to the next slide. Now, how this looks in a clinical situation and ultimately led to the FDA approval based on the trial that you see summarized in the slide here. This was a 2-to-1 randomization for T-Vec versus GM-CSF that was given subcutaneously, and the T-Vec is administered intralesionally. So the physicians injected this particular herpes virus directly into the tumor cells. We actually here at our site had the privilege of participating in the clinical trial, and I've had a very, very significant responses that I can report on for this trial. And so almost 300 patients were randomized to the T-Vec arm, and you see durable response rate was 16.3% with an overall response rate of 26.4%. Now, these numbers are lower than what we're currently sort of spoiled by with the cell therapy that I just introduced to you with the TIL therapy, and also judging by the immune checkpoint inhibitors. The way I sort of judge this therapy to be useful in the future is in combination and sequence with other immunotherapies. But even as it stands all by itself, for patients who are refractory to cytotoxic or other immunotherapies, this is a very meaningful intervention where you can see the median overall survival 23.3 months in the T-Vec arm, and also very, very well tolerated. Grade 3 and 4 events were rarely seen, and typically due to the injection of an oncolytic virus into an already inflamed tumor tissue, causing cellulitis in 2.1% of patients. And there were really no fatal treatment-related adverse events. It's currently being studied, as I said, in combination with checkpoint inhibitors for the treatment of patients with previously untreated, unresected stage 3B and 4 melanoma. Again, the cream of the crop patient population that we're trying to recruit to these clinical trials are our immunocompetent patients who are not heavily previously treated. Let's move to the next slide. Now, I wanted to just introduce one of my own patients that we recently treated at our institution here at Oncology Specialists in Park Ridge in Illinois, where we had the pleasure of participating in the Cavatak clinical trial that is sponsored by Viralytics. They're using a different platform. It's the Coxsackie virus A21 platform, which is a naturally occurring virus that is responsible for typically very mild upper respiratory tract type of infections And very similar to the T-Vec approach, it's a very potent oncolytic virus. It's also injected intratumorally or intralesionally and induces lysis of the tumor cells, again, with the idea that you would like to expose the host immune system to the extra intracellular tumor-specific antigens in the process of tumor lysis. Let's move to the next slide. So the patient that we treated here at our institution was a 48-year-old female. She had a very deep ulcerated malignant melanoma on her first hallux that was a stage T4B, but N0. She had a wide local excision, which really was amputation of her hallux, and sentinel lymph node biopsy at the time of her presentation, which was negative. But very shortly after surgery, she suffered from a local disease recurrence, having developed a subcutaneous nodule on the same leg, for which we performed an excision and ultimately identified an in-transit recurrence of her malignant melanoma. 6 weeks after that excision, she developed multiple new in-transit lesions on the leg, which ultimately confirmed the unresectable state of her disease. At the time, this was just after ipilimumab was approved for the unresectable stage 3C and stage 4 malignant melanoma setting. So we treated her with this. Her tumor was BRAF negative, disqualifying her from targeted therapy. And so she received 2 cycles. This drug is given intravenously once every 3 weeks. And she very rapidly progressed, needed to be admitted emergently to the hospital with severe abdominal pain, nausea, vomiting. And we identified stage 4 disease with omental involvement. She had very, very significant omental caking. We performed a biopsy and confirmed her stage 4 presentation at that time. We elected to treat her with 1 course of high-dose interleukin-2. This was at a time where the PD-1 inhibitors were not on the market yet. And again, she was not BRAF positive. And so she tolerated 15 out of the 24 planned doses and had actually a very significant and rapid response to this therapy with complete resolution of her abdominal disease, but still had persistent lower extremity lesions that were essentially unchanged with the administration of IL-2. And at the time, because she was, again, very asymptomatic, we felt that we had time to work with the immune system and really wanted to complete the course of ipilimumab therapy and administer 2 additional doses of ipilimumab at the time. But it was even through treatment, but also shortly after completion of those 2 cycles, that her disease was not responding, and she had very significant progression, but limited to her leg. And so at the time, we had access to this Cavatak Coxsackie virus clinical trial at our institution. And so I enrolled her into this clinical trial and subsequently injected her intralesionally with this genetically engineered virus for the subsequent 4 months, to which she achieved a complete remission. She has enjoyed complete resolution of her palpable disease, and we have now been able to confirm a complete remission since October of 2013, which is now 28 months ongoing. If you can go to the next slide, please. I included her initial PET scan at the time when we enrolled her into the clinical trial, and she had multiple lesions that don't really depict so well here in this telepresentation, but you can see the larger lesions that show up that were clearly palpable, highly FDG avid, and even on the CT portion on the lower left panel that you see here, a significant subcutaneous nodule that was palpable, FDG avid, and easily injectable. If we can go now to the next slide. This is her post-treatment PET scan, completely negative, and she has maintained negative scans essentially since she achieved the complete remission, now 28 months and counting. Excellent performance status, is in gainful employment, is raising her young daughter. It's just an amazing thing to be an oncologist at the bedside and witnessing such a miraculous turnaround for somebody who ultimately was destined to die of their disease. Now let's move forward, and so I think we're going to come to the summary slide here. So the key takeaways for today's presentation are really that in the future there will be a number of immunotherapies in addition to the cytokines and checkpoint inhibitors that you already have in your pharmacy today that will be available to treat patients with cancer, including the vaccines that we discussed, which introduce the immune system to tumor-associated and ideally tumor-specific antigens, introducing the immune system to, or inducing the immune system to recognize and attack tumor cells associated with this antigen. We exemplified Prosca and the CRS-207 platform, as immunotherapy vaccines currently in development, and if everything continues as promising as the early phase clinical trials looked, I would anticipate that this will achieve FDA approval in the near future. We also talked about the great advantage in cell therapies that we have seen in early clinical trials, including this TTL-019 in acute lymphoblastic leukemia, which is really a breakthrough therapy that seems to be extremely promising, and the LN-144 in a malignant melanoma setting, looking at TIL cells, looking at the patient's autologous immune cells, which are engineered then to recognize their own tumor cells, so a very, very sophisticated, highly effective approach to our patients. And then lastly, we discussed the oncolytic viruses as a type of immunotherapy indicated for the treatment of melanoma and currently approved on the market in the form of T-Vec, but multiple other ones in clinical trials, and hopefully not just limited to melanoma, but other solid malignancies as well. And I would like to open the floor to questions. I know we've been able to sort of get those questions in even as I was talking, and I know I have Jake right here on my side to help me moderate those, so let's see what questions we can answer.
Thank you, Dr. Hallmeyer. It's a very informative presentation, and we do have a couple questions that came in. The first one actually has to do with the use of chemotherapy in the future, and it's interesting because you had talked about it with regards in combination with CRS-207. So the question is, with immunotherapies already in the market and others with newer mechanisms of action demonstrating impressive response rates, what role do you think chemotherapy will have within the cancer treatment paradigm in the future? And do you think immunotherapies will eventually replace chemotherapy completely, or maybe relegate chemotherapy use as a much later line therapy?
Yeah, love that question. I think it's an excellent question. So I think we are sort of opening the book of immuno-oncology, and we're in the first few pages. I wouldn't even say in the first few chapters. We're in the first few pages. We'll have to see how thick that book really is and how many pages and how many chapters are ahead of us. The way I sort of view the combination of therapy of available agents today is really in conjunction with each other. I don't think that for the majority of our patients that we have reached the point yet where immunotherapies have a true standalone role. For very few patients in the setting of malignant melanoma and with advanced lung cancer and kidney cancer, the immune checkpoint inhibitors can in fact induce durable remissions, but that is still unfortunately a relative small minority. In the majority of patients, we still need to think about sequencing to conventional therapies or combining with conventional therapies. And so in that, cytotoxic chemotherapy, I believe, will still unfortunately hold a relatively strong position for the foreseeable future. And moreover, I believe that chemotherapy ultimately can be helpful in inducing better immune responses, deeper immune responses, and maybe even more durable immune responses as it comes to combination therapy. Because if we sort of think about what chemotherapy really does, it in principle leads to cell lysis and inflammation. And those are typically helpers to immunotherapeutic interventions as well. If we can have lysis of tumor tissue that exposes these cells, exposes their internal cell material to our immune system, we can deepen and broaden the immune response that we can ultimately induce with combination immunotherapy as well. So my long-winded answer to that question is I think that chemotherapy still is here to stay, and at the very least I foresee for the foreseeable future that chemotherapy will be used as an adjunct and certainly as sort of a treatment of last resort for many of those patients that still will not achieve the complete durable remissions that some of our patients do. But if I speak from the heart of my heart, I am hoping that we are in fact embarking on a future without chemotherapy that will be purely based on targeted immunotherapy that is specific, highly toxic, and can't function without any helper conventional therapy, may it be targeted therapy, surgery, or radiation.
Thank you, Dr. Hallmeyer. So we do have another question, and this question is in regards to cell therapy, immunotherapy.
Yeah.
So most agents used currently to treat patients with cancer are given orally or via injection or infusion. CAR T cell therapy is interesting, however, in that it requires the collection of the patient's T cells, which then have to be genetically modified, expanded, and then reinfused back into the patient. Now, logistically, do you envision this type of therapy being difficult to administer in a community hospital? And do you think there will be any access barriers, once this type of therapy is approved, in the hospital?
Yeah, it's another very, very good question. I think what ProVench has taught us is that does not seem to be a big barrier. This is a very similar approach where patients had to undergo leukapheresis. These cells were then ex vivo expanded and then were reinfused, and in many, many cases in community cancer centers, including ours. And so we felt very, very comfortable with that. Now, do I think that a solo community oncologist in central Kansas is going to be participating in such therapy? It's probably cost prohibitive, because ultimately the leukapheresis, the cell expansion process, etc., is difficult to centralize, and so or whether it's difficult to decentralize. It's difficult to do in smaller community centers. But what we have seen with the ProVench type of approach, and what I think we will see with other cell therapy approaches, is that when patients have the possibility of having a significant treatment response to a single time therapy, because these therapies typically do not need to be repeated, patients are often willing and able to travel to the treatment centers that have the expertise and have the sort of technical finesse to pursue this type of therapy. This is different than sort of where we come from historically from in the medical oncologic world, where patients are typically, asked to come to a community oncology center every other week or every 3 weeks for an infusion for months and months on end. Many of those immunotherapeutic interventions are short-term, and in the world of cell therapy are typically a one-time intervention. And so in that, I do believe that even with this being a difficult, technically highly specialized type of therapy, that there is a real future even in a large country like the United States.
Thank you, Dr. Hallmeyer. Once again, thank you very much for your very informative presentation. I think that's the amount of time we have to answer questions. So at this point, I will hand it over to Lorna.
Thank you, both Dr. Hallmeyer and Dr. Ginto. The presentation was very engaging and very informative, so thank you. And thank you to our audience for participating today as well. The webinar and slides will be available on our website, which again is accc-iclio.org, by the end of the week. And all registrants will receive an email with the URL link as well. Please be sure to also check out our whole playlist. We have a whole library of our archived ICLIO webinars that we've had presented through the year. And so please take a moment to check out that, and you can watch it on demand at your leisure. So again, thank you everyone, and hope you have a great rest of the week.
Thank you very much. Have a great day.